me to set this up. So in the wake of the disaster at Flint, nationwide there's been a lot more attention drawn to the problem of lead poisoning. And a number of partnership members have thought about getting engaged in the issue where they weren't already. Policymakers have become much more aware of the issue and much more concerned about it. And so Catherine and I felt that it would be appropriate to try and give both of our networks tools to work on this issue, given that the heightened visibility creates a new advocacy opportunity. Catherine is with the Green and Healthy Homes Initiative, which for Partnership for America's Children, you should know that, members, you should know that that used to be the National Coalition to End Lead Poisoning, Childhood Lead Poisoning, and they are really the national experts on how you work at lead poisoning on a local level, and they have a network of groups around the country that do that. For Green and Healthy Home Initiative folks, the Partnership for America's Children is a network of 52 organizations around the country, most of them working on state policy, about 7 of them working on local policy, but many of the state ones also work on local policy. And they are multi-issue child advocacy organizations so that they work on a wide range of issues affecting children. And a number of them, including Elizabeth Burke Bryant and Rhode Island Kids Count, have worked on lead poisoning in the past. So the goal of this webinar today is both to give both networks the tools to address this issue in light of its heightened visibility, and also to introduce you to each other so that you can understand how the two organizations from the two networks can work together effectively. So that's pretty much why we put this together.
Great, thanks so much, Deborah. So just to give you a little bit more of an overview of what we'll be covering, we're going to start with some basic information about national indicators of healthy housing needs and the value of housing interventions, and especially what we call the GHHI model for comprehensive interventions. So that'll be a broad overview with some talking points, and when you get the slides, you'll have reference information for everything we cover. So you can use that for your own local policy agenda if you're in need of that information. And then Elizabeth Burke Bryant will go over some of the work that she's been doing in Rhode Island, which is excellent information that I'm looking forward to going over. And we'll talk about how the Kids Count research has informed policy and how that's been used in the local partnership in Rhode Island. And Margarita, Robledo, Guedes from the Green and Healthy Homes Initiative there will give us some background on the partnership. And we'll finish up with giving you some additional resources that are examples of state and local policy success stories, as well as some tools that you may need if you're looking to connect with partners locally. So to get started, I will go over some of our main national measurements for the need for healthy housing interventions. So for people joining us from GHHI, this may be a bit of a review, but you'll be familiar with some of these indicators, and some of it also may be new to you. So I hope it's useful. But kind of a Big 10 or broad overview is that we have a high number, 9 million families living in unhealthy homes in the U.S. And that creates a huge cost burden, not only for families that we work with, but also for our government services, as well as our nonprofit and philanthropic organizations. And that cost comes from some of the biggest costs in terms of public health spending come from lead poisoning prevention, lead poisoning, as well as trip and fall injuries for seniors and asthma-related illness. And these are all health issues that are preventable with a healthy homes intervention. So these are certainly costs that are preventable and equate to 3% of our healthcare costs nationally each year. And in addition to the unhealthy housing conditions, inefficient homes create huge cost burdens for our communities as well as our families. And we have found that low-income households spend somewhere between 14 and 20% on average of their monthly income on energy costs. For families of higher economic levels, that is more like 3.5%. So we really see the impact of that burden and find that families have a trade-off issue where if they're paying a lot for energy costs, if they're in inefficient homes, they're having to trade payments for utility bills that could be put toward other family needs like medical costs, education resources, and similar needs for families. So lead dust in the home is the primary source of lead poisoning. And as Deborah mentioned, we've really seen a national interest in lead exposure through our water systems because of Flint. But what we find and what the research shows from the CDC is that lead dust is still the primary way that children are exposed to lead, and soil can also be a source of exposure that's common and something to consider. But we have a lot of information on our website about lead poisoning sources that show this connection, and that we also know that about over 500,000 children nationally have lead poisoning with an elevated blood lead level of 5 micrograms per deciliter or higher. Children are living in 24 million homes with lead paint hazards, and, or excuse me, I'm sorry, 4 million children are living in homes, but there is a large percentage of our national housing stock that has lead paint hazards. So that's, excuse me for that, that's 24 million homes with lead-based paint hazards in them. Lead can cause lots of health problems, and children and pregnant women are especially vulnerable to absorbing lead. And lead exposure at any level can cause neurological damage, which can lead to conditions like ADD, ADHD, hyperactivity, diminished IQ, and in adults at high levels can also cause cardiovascular illness and other issues, including hypertension. So lots of health hazards or lots of health conditions related to lead poisoning. And children who are lead poisoned are 7 times more likely to drop out of school and 6 times more likely to become involved in the criminal justice system than kids who are not exposed to lead. An additional home health hazard that we have a lot of information on are asthma triggers, because 40% of emergency department cases that are caused by asthma are the result of home-based asthma triggers. And that can be anything from mice and rats and their droppings and cockroach frass, as well as dust mites, to environmental tobacco smoke being another major one. And that creates a huge cost burden, as we've talked about, and as well as a high level of intake through our emergency departments for asthma treatments. So this is a big burden to consider. So when we are thinking about our policy platforms in our local and local communities, as well as at the state level, working with our legislatures, you will often hear from political leadership a need to get information on the return on investment for housing interventions and for programs. So these are some numbers from recent research that show for every dollar that's invested in lead hazard control and housing, there is a return of somewhere between $17 and $221. And also a significant return on investment for asthma trigger control interventions, somewhere between $5 and $14 to every dollar invested. So these are important figures to keep in your resources as you start to develop them out, or if you have them for your local communities to use as your tools for communication with your political. And some other information that you may find useful having to do with injuries and accidents. because injury is the leading cause of death and disability among children and young adults. And oftentimes we'll think about those injury rates related to cars, and you'll hear that a lot from your public health officials, but they also, those injury statistics that you get from public health will include household injuries, as well as fires and choking and chemical poisonings. So that's something else to look for in your public health resources locally. And again, some energy inefficiency information and some of the related health conditions to show the need for more investments in energy efficiency, because extreme heat and extreme cold are both conditions that can impact childhood health as well as health for seniors. And we know that those burdens are related to the overall condition of housing when we're thinking about it from a comprehensive standpoint. So if you were looking for local resources, these are just some links and some places to look if you're trying to find information on those indicators that I wanted to share. First, for lead poisoning surveillance being the CDC website, which the link is included here for the up-to-date state-level surveillance data. But that may be something that you can pull more locally through your local or state health department if you have access and partnerships with those offices, as well as for lead poisoning risk. If you're looking for that information, you may want to try to access that through the U.S. Census or the housing survey if you're in a large enough community. And if you have not used the U.S. Census before, the American Fact Finder website, and have problems accessing the data there, I highly recommend accessing some of their training materials. There are online tutorials, and then there's also information about how to get notifications if there are local training sessions, which the U.S. Census does pretty regularly, and I've found them to be very useful. And then some additional places to look for asthma prevalence information. You can certainly go look for surveillance data through your local health department again, and also hospitals. Any nonprofit hospital every 3 years is required to do a community health needs assessment, and they should have those assessments on their website. Asthma being so prevalent, many of them will include data on the rates of asthma hospitalizations and things along those lines that you may find helpful. For home injuries, again, the health department, but also your state insurance commissions will probably have information, especially related to fire-related accidents and deaths. Weatherization needs, there are a variety of resources there, including the housing survey, but also your local weatherization assistance programs, and also your state public service commissions or utility organizations. And with housing conditions, you'll want to look at your local, housing departments, any of the agencies that are administering funding from the Department of Housing and Urban Development will have to put together comprehensive plans. So those plans will have some of those indicators, and that may be a spot that you want to report some of your indicators to as well, so they're included in the planning process and that guides the way that funding is spent on housing needs. So with that, I will turn it over to Elizabeth Burke Bryant, and we will see how Kids Count has guided this process in the state of Rhode Island.
Thank you so much, Catherine. I'm looking forward to taking you through some slides quickly in order to bring you up to date on just one child advocacy organization, Rhode Island Kids Count's contribution to making sure that the best available data on lead poisoning is used as a real alarm bell to make sure that there's a lot of action to eliminate and eradicate lead poisoning among children. Next slide. So the context for our Rhode Island situation with lead, I just want to thank our partners from Green and Healthy Homes. It has been great working with them for a number of years to really make sure that people understand that the age of housing stock and condition of housing stock really exacerbates the issue of lead poisoning
in communities. And so we started just a couple of years ago. It's actually been in our book for several years now, an indicator on children living in older housing. And it's a comparison of Rhode Island and the rest of the United States. And we were able to find that a full 82% of Rhode Island's low-income children between 2010 and 2014 lived in older housing, and that Rhode Island has the highest percentage of low-income children that live in older housing stock in the nation. So when you hear what our situation was with lead poisoning of children based on the condition of housing 20 years ago, that we've been able to really have a dramatic improvement in, this context of older housing is something I wanted to start with. Next slide. So what we did when we started Rhode Island Kids Count is that we really were made aware by our partners at the health department that Rhode Island really had a true epidemic of elevated blood lead levels among its children, and that we really needed to get the data out there. So we started our organization by releasing our first Rhode Island Kids Count fact book, our annual portrait of how children are doing, back in 1995. We have released it every April ever since. We started with 22 indicators. Now we report on 71 each year. We report every indicator for the state as a whole, what we call the four core cities compared to the rest of the state, and then every city and town. We don't use county system of government. We really use city and town. And even though our fact book has grown so much, I'm proud to say that one of our core original indicators was then and still is children with lead poisoning. And what we did in order to really make this an accessible indicator is that we prevailed upon our good partners at the Rhode Island Department of Health to give us their volumes of data that they were collecting on elevated blood lead levels, all in very medical-sounding terminology of milliliters in bloodstreams, UG/DL, which when you talk to legislators, their eyes would glaze over. And instead we put it in the more accessible terminology of thinking about real children. So our indicator has always been about the percentage of children entering kindergarten with a history of lead poisoning. We have a link for you here. We would really invite you to, oh, and I just want to stop for a second and say the difference that made, especially when you see my next slide about just how prevalent this problem was back in the late 90s, mid to late 90s, is that it made people think about that line of kids at the schoolroom door lining up for their first kindergarten class of their kindergarten year. And when you see the numbers of kids in our state, not just in the core cities, but all over the state, that were affected by this very preventable pediatric health problem, it was just a wake-up call for everyone. Next slide. So this slide dramatically shows the reductions of Rhode Island lead poisoning of its young children. Again, it's children entering kindergarten with a history of elevated blood lead levels. The level for that is now greater than or equal to 5 UG/DL. I do want to point out that what was considered an acceptable level back 20 years ago was higher than that. When we first started reporting on this indicator, it was 14 UG/DL, and then it was 14, and now it went from 14 to 10 and now down to 5. But the thing that I really want to show you is that back in 1997, among our first data for this, we were showing that in the 4 core cities, 84% of our kids entering kindergarten had elevated blood lead levels. In the state as a whole, 71% of our kids did, and in the remainder of the state, to really show that difference between where low-income kids are living and higher-income kids, that first line and then the last line, the difference between 84% of kids in the core cities versus 62% in the remainder of the state. But any way you slice it, that's a huge, huge number of 71% of all kindergartners entering kindergarten in 1997 with elevated blood lead levels. That was based on the 1995 data that went into our fact book that had predictive ability because of the screening of children in their pre-K, pre-kindergarten years. So I want you to see the steady decrease And what we do say at the end of this is that we are now down to 8% of children entering kindergarten with elevated blood lead levels, 13% of those in the 4 core cities, and 5% in the remainder of the state. We do have almost 1,000 children who are have elevated blood lead levels, and what we always say is that our job is not done until there are no lead-poisoned children, because as we've both said, it's entirely preventable. So I was saying that putting this data in front of people was really a wake-up call. We never take, we always very much share credit for the response in Rhode Island. I think ours was an alarm bell function. As Debbie said at the beginning of her remarks, the Flint, Michigan situation has put this unacceptable children's health issue much back on the radar screen. And you all in your states with your regular data reporting can go a long way in raising the awareness of policymakers that this is a preventable pediatric problem that seriously affects children's brains that can be prevented, and that there are ways to get together as a community and address it in terms of a few of the things that I'm going to go to take you through next about what Rhode Island's response was. Next slide. So we had some of the earlier lead poisoning prevention programs back in 1996. Rhode Island was one of the first states to establish a childhood lead poisoning prevention program. And then in 1991 passed a pretty comprehensive lead poisoning act. As you can tell, based on the numbers I just showed you from 1995 and 1997, there was still a long way to go, and so that legislation didn't have an immediate impact, but it laid the groundwork for building on our legislative efforts that happened after that. So I would say that when we look at some of the legislative action that you might be interested in, we did pass the original act. We had the Lead Poisoning Act in 1991, and then we had a very high-profile suit where the Rhode Island Attorney General brought suit against paint companies, saying that they knew much more than they said they knew about the damaging properties within lead paint, and asked for a judgment against the paint companies. The long and the short of that, it won at the lower court level and then was reversed at the Supreme Court level, but it did raise a lot of awareness about the issue of lead poisoning in Rhode Island and what we need to do about it. Then in 2002, we passed the Rhode Island Lead Poisoning Mitigation Act, and that was a pretty comprehensive bill that said we need to get to the site of what is poisoning our kids, our condition of our housing primarily. And so this law mandated public notification of lead violations and various remediation requirements. I would say that that law was successful in some ways. I say where it fell short, many people agree, is that it exempted a lot of properties. And so now what we're looking at is where are the worst violators of lead issues that are poisoning kids, and are they among the properties that have been removed from this law, exempted from this law, and how do we get this law changed to include more of those properties and more effective enforcement. We've also had some state general revenue appropriations for the Childhood Lead Poisoning Prevention Program. So that's been a state revenue, a state funding item that we've had to continuously to make the case for, that basically we can find where these lead poisoned kids are, but we need to be able to follow through and get them the treatment they need and to make sure that the houses are cleaned up. So I think that's been another part of our success, has been to get the general revenue appropriation for the Childhood Lead Poisoning Prevention Program. And then, you know how it is, all of us are wearing the same hats when we do our lobbying at our state houses. It's sometimes hard to plan for some state funding that is year by year programmatic line item in your state budget that can very much be vulnerable to things that are happening with budget deficits and so forth. So we were really pleased that in 2014 the Rhode Island General Assembly increased real estate conveyance tax for lead hazard abatement. affordable housing and homeless prevention, $2.8 million annually, specifically targeted for those uses, including lead hazard abatement. And then more recently, in response to Flint, the General Assembly mandated a baseline test of lead and copper in water supply of each local government, public school, and licensed child care facilities in the state. So quickly going to go through a few other of our legislative requirements that has really given way to all of the data that we've used as a policy lever. We do have universal screening of all children age 6 and under each year, including 2 blood lead tests by age 3. These screenings have to be reported to the Department of Health within 10 days, which, depending on the level, can trigger an offered home and environmental inspection. There are some religious exemptions, so those are included in the law, but by and large, we do have universal screening. Our law mandates that all insurers cover the expense of lead screening and related services, including diagnostic evaluations, and screenings are provided at no cost. And we do have a law that mandates lead-safe certification for all licensed daycare, child care facilities, preschools, public and private elementary schools, public playgrounds, shelters, and foster homes that are serving children under 6. So we tried to say, where are the highest concentrations of kids going to be? And let's not just stop our fight against lead poisoning in terms of making homes lead safe, but let's make sure that we take places where young children are in very large numbers and make sure that those environments are lead safe as well. So next slide. So the results, there's still, even with universality and universal requirements, you still have a job to do as a state to make sure that you take advantage of those laws and policies and do get kids screened. So in 2015, 77% of 18-month-olds received at least 1 blood test, lead level test. 84% of 3-year-olds received at least 1. And then there was some drop-off that we're looking into of 3-year-olds. Only 55% received the required 2 lead tests. We do have another advantage, that all of our screening data is put into our KidsNet Comprehensive Children's Health Database in our state, and that is great because then we can kind of compare notes, as was mentioned by Catherine earlier. We want to see the relationship between asthma, between code violations, and kids with lead poisoning, and KidsNet data is able to take in all of that data and manipulate it in a way to see how all of these indicators as a group, what they tell us about children's health and well-being in Rhode Island. Just really quickly, Medicaid is key to our success in really ramping up our efforts to both screen and treat kids. In Rhode Island, about half of the children under age 6 with elevated blood lead levels are enrolled in Medicaid, which in our state is called our Right Care program, which is a blended Medicaid CHIP program. And we do incentivize our Medicaid plans. As early as 1998, Rhode Island Medicaid launched a performance goal program to incentivize quality and access within Medicaid managed care. And lead screening has long been a performance measure for our insurance companies that provide right care coverage. In 2015, 83% of children age 2 with right care received a lead screen, and our right care Medicaid performance level met or exceeded the 75th percentile. And then this is a really interesting, unique idea, and I'll never forget when it was decided upon. We, back in the late 90s, as we were really just coming on really strong to try to reduce our lead poisoning levels in Rhode Island, it was seen time and time again that the condition of windows in dilapidated tenements was, by and large, a huge problem, as well as lead and dust around homes. And I remember at the time that Christy Ferguson, then our DHS director, who many of you know through her national work at George Washington University, and she, previous to her position in Rhode Island, had been on the late Senator John Chafee's staff in Washington. She was a real Medicaid brain from her work in D.C. On children's health in the United States with Senator Chafee. She just kept getting tired of seeing reimbursements through Medicaid for treating children whose brains were already compromised by high lead levels. And she said, why don't we do Medicaid for Windows? And we said, Chrissy, what are you talking about? And she said, Medicaid for Windows. I would rather take precious Medicaid dollars and have a Medicaid code that will allow families to pay for the cost of making their Windows lead safe than pay the cost of failure of having their kids have to have painful treatments after their lead levels were elevated. So that was what we called Medicaid for Windows. We were able to do that through a Medicaid 1115 waiver, and it's still on the books, and we think it's a best practice of trying to get in there and do prevention rather than the cost of failure. I think that we've already been through the next slide. Non-medical case management services are provided by 4 certified lead centers throughout the state, and they do things including lead education, nutrition counseling, information on cleanup, in-home education, environmental intervention, and really the coordination of medical care with families' primary providers. I think we can skip the, we want to also keep our eye on the ball of significantly lead-poisoned children under 6. Starting in 2015, children are considered to be significantly lead-poisoned if they have a single blood test result of greater than or equal to 15 UG/DL. And we are pleased, again, that we've made progress with this horrific indicator. The number of children under age 6 who are significantly lead-poisoned has decreased by 76% over the past 10 years, from 349 in 2005 to 84 in 2015. But again, those 84 children should not be significantly lead-poisoned in 2016 and 2015, and we have our work to do and our work cut out for us to completely eliminate that number of children with very elevated blood lead levels. We do have one last thing which I think shows, we're on the slide that starts with negative impact on academic outcomes. We have been working in partnership with some other researchers that have studied Rhode Island children with a history of lead exposure have decreased reading and math proficiency in the 3rd grade, and that they have pinpointed that most significant academic declines occurred in children with the highest blood lead levels and those living in the 4 core cities with the highest child poverty rates. And children with lead exposure have increased risk of absenteeism, grade repetition, and special education services. So when you're making the case of why this matters, it not only matters because we know more than enough to say that we know everything we need to know to completely eradicate this problem in our country, but we also know that we're throwing good money after bad in our education system. The longer we let it go by, that there are far too many children that are still being lead poisoned, which is really leading to negative academic outcomes. So we have a lot to go on in terms of looking at this from a whole child perspective, and even if your state or community has made progress in recent years because there's been more awareness, more parent and landlord and other people's education, we still have an obligation to completely eliminate lead poisoning for our kids. So that's it, Catherine. Thanks so much.
Great. Thank you so much, Elizabeth. That's great information. And I'm going to give Margarita from the Green and Healthy Homes Initiative an opportunity to talk about the Rhode Island partnership and the Alliance for Healthy Housing or Healthy Homes, and how they have worked with Kids Count over the years to develop policy agendas and implement them in the state of Rhode Island. Margarita, are you able to speak? I think I see you connected. Margarita? Okay. If she's disconnected, I'll give her an opportunity to rejoin us. Okay. So we'll come back and give Margarita an opportunity to talk about the Alliance as soon as she can join us. And so I will go into our next set of slides. to talk about some additional state and local policy resources and also give you some recent successes in lead poisoning prevention policies that have been happening, as well as some tips for developing a local or state policy platform. And the tips listed here are things to think about if you're getting started, but also, you know, want to make sure that everyone knows that the Healthy Homes work happening in your state may be ongoing, and you may be a part of that already. So these are resources that hopefully will be useful for anyone joining us, no matter what stage you are in developing a policy platform. But the resources that we have developed through the Green and Healthy Homes initiative are really useful no matter who's involved in the policymaking process. We take a bipartisan approach to developing policy, and also look for bipartisan support when we're looking for legislative sponsors of the work that we're doing at the policy level. We also, through our local partnerships with the Green and Healthy Homes Initiative, we'll often think about funding and also how new laws will be implemented and enforced. And as Elizabeth covered, that's a very important aspect of thinking about the impact of the policy that you're developing, if it's something that you'll actually be able to implement and enforce and see some results from in the future. And you may be looking at a pretty broad coalition of supporters, and as you probably already know, it seems to me that through the Partnership for America's Future, or Partnership for America's Children, you're hitting a lot of different policy issues that impact children. So your coalition seems quite broad, and I think that in terms of home health, safety, and energy efficiency, you're used to working with diverse groups, and they speak different languages in terms of the types of policy work that they're focused on. So that's just something to keep in mind as you're creating an agenda with diverse people, that you may have to learn some of those languages or work to interpret the way that you're presenting your information. And with that, you know, in the coming year, and I think many of us will experience this in the future. I know it's certainly true where I am in the state of Mississippi, that we have to look at a broad section of proposed legislation to see where we can embed healthy housing resources. And so, you know, while we typically look at the housing and health legislation, and we work with our city council here in Jackson, Mississippi, to try to ensure that lead poisoning prevention resources are included where it makes sense in their legislative agenda, we may also be looking at infrastructure projects. And that is something that we are evaluating currently, and are looking for ways to include our lead poisoning prevention data and infrastructure plans to ensure that we're addressing lead risks that are present in our, particularly in our water infrastructure this year. And want to also make sure that any of our tools that we're developing, you know, with these data points and our communication tools, that we're getting that out to our legislative groups, as well as public education groups, or, you know, developing those in a way that we can get them out to the public and grow support for healthy homes. And there are lots of ways to do that, and we've got case studies that we developed at the Green and Healthy Homes Initiative that help tell those stories about what can get accomplished and show the impact at the family level. And so where possible, it makes a lot of sense to develop those resources. And I think Margarita was able to rejoin us, so if we have a chance, Margarita, if you can unmute yourself, we'll give you an opportunity to, we'll go back a little bit in the agenda so you can talk about the Alliance for Healthy Homes.
Thank you, Catherine. We got disconnected, not sure how, but I think one of the key elements that I wanted to share with the group in regards to the work that we do in Rhode Island as an outcome broker is, without the data and without the kids count being on the forefront of, you know, being a watchdog in regards to data, we wouldn't be able to convene the group of members that we have. for the Alliance for Healthy Homes. We're in the steering committee meeting as a member, and one of the key issues that we're actually working on right now as we speak is the lead brief, which we're putting together with all our partners based on data. What can we make better to make sure that no child in the state of Rhode Island is lead poisoned, period. And like I said, going back to the history that Kids Count has so eloquently put together, it becomes a catalyst for a great conversation to have among partners on the table like DOH, the Housing Resources Commission, GHHI, and all the different partners that we want to really push the agenda and create this lead briefs. How can we make this better? How can we have enforcement be better in the future for the children of Rhode Island? And that could not have happened without having data to create great policy actions right now and moving forward. So I do want to commend the work of everyone at the table, and Kids Count especially, to be able to facilitate those conversations among the partners to the Alliance as of today. One of the other things that I wanted to share also that has come in the front of creating more leverage and more resources for Rhode Island is the training of housing inspectors and code enforcement, which has been done to the Lead Action Project and also has been done to the Housing Resources Commission and GHHI to expand, a healthy homes environment. What does that mean for the housing inspectors and code enforcement to understand how do we need to protect children under the age of 6 in the state of Rhode Island? So that has been a wonderful kind of forefront with the data and having policies in place, but how can we go the extra mile and really protect the children that we work so hard to protect through the different networks that we have. And lastly, which is, I think Elizabeth Burke mentioned this, which is the testing of water and lead and copper, which is something that the state put forward. Now the Housing Resources Commission is creating a study to test daycare centers and public school systems, water supplies, to be able to have a report and best practices nationally. And we see ourselves as GHHI being able to, put our voice and our senses nationally what the best practices are, to have that conversation, to have local, state, but also national kind of conversations, how we can have those tools and make this better for the state in Rhode Island right now. And one of the things of Medicaid that Elizabeth Burke mentioned is one of the things that was done many years ago that I'm hoping to see as a new policy issue is to have Medicaid reimbursed for certain interventions, so children also get the benefit or interventions not only for lead but for asthma moving forward. And finally, one of the greatest things to have in policy and data to back it up and to explain to policymakers is right now that we have the Pay for Success in Rhode Island for asthma interventions in healthcare, which will be a cost benefit for the state of Rhode Island. To me, without the support of partners and the data that we have, we wouldn't be in this kind of outfront to have our governor support that vision of Pay for Success and how can we move the agenda forward. At the end, to protect children under the age of 6, regardless of where they live. It is one of the things that I have learned throughout the years in my work also as a community organizer in the past for lead poisoning prevention and now as an outcome broker, that data really drives the agenda for people to understand where we are and where we need to be. And without those partners nationally and locally to be able to help us and help our partners statewide, we wouldn't be able to really understand the bigger picture, but also the steps that we need to do along the way. And Rhode Island is one of the well-known states for enforcement. We have really reduced lead poisoning issues over the years, as the data shows with the previous slides that Elizabeth Bryant showed, but we still have a lot of work to do to really eliminate it to zero. And I think it's a great example for people listening today that use the tools, use the experience of the network locally and nationally to move your agenda forward individually. As everybody is at different stages, I think the stories that we share today really show what commitment over time can produce, but also how we can make things better locally as we look on a close eye to make sure that we don't go back, but we always move forward. And that's what I wanted to share with you, Catherine.
Okay, thanks so much, Margarita. And I will advance a bit so I can just take a few minutes to go through our last few slides here and talk about some of the state and local policies that we recommend you looking into in your state if these aren't already implemented, And again, I'll through the sharing of these slides, you'll have resources connected to our website and other guiding documents for policymakers that will give you more details on each of these points. But the points listed here are different policy initiatives that have been implemented in communities across the country at the state and local level to impact lead poisoning prevention. And I'll get into a few of these as we go forward here. And some of our best practices recently have been in the state of Maine, which has last year passed legislation to bring their standard for elevated blood lead level at the state level in line with CDC recommendations currently to be 5 micrograms per deciliter or higher, and that's meant that their state has been able to invest more in environmental investigations of children with elevated levels at a lower rate. And I think prior to this they were at maybe either 10 or 15. So it's meant a higher caseload, more environmental investigations, but of course more actions being taken to reduce lead risks for children. So that's a great example of a really strong policy. And then as a support of that, in the city of Lewiston, Maine, they have improved their lead-safe demolition standards, which is something that we've seen in many communities, especially those that are having to do a high level of demolitions. They're looking at how they can reduce lead prevalence in the demolition process and how they're getting rid of any lead materials from older homes. And then in the city of Buffalo, the mayor has implemented a 10-point lead poisoning prevention plan that is included a number of really strong regulations, including rental property lead certification and annual lead grant funding. And those are some great resources or pieces of model legislation. And again, some more city-level regulations. In Toledo, they passed an ordinance to require lead remediation and lead certification of rental properties. And I know lots of communities that GHHI works in is looking at how they can increase the number of inspections that are happening of rental properties, especially those that are at market rate but occupied by low-income households, because we know that those are typically the households that are that aren't inspected in any kind of way, that you know, if we've got children living in publicly assisted housing, especially through the Section 8 voucher program, there's a requirement for an annual inspection that includes a look for chipping and peeling paint. So it's really oftentimes in communities the market rate housing that is serving low-income families that's kind of left untouched. So finding ways to touch those properties is very important. Similarly in the city of Rochester here. And in the state of Maryland, where, as Deborah mentioned, the Green and Healthy Homes Initiative started as the coalition to end childhood lead poisoning in the city of Baltimore. They have done so much work over the last 30+ years to get legislation passed at the state level to improve lead poisoning prevention and reduce lead risk in communities in Maryland. So that's been 30 different acts, and there is a summary document on the Green and Healthy Homes Initiative website that details all of those. These are some of the more significant lead policies that have been passed, including another window replacement plan, as well as inspection plan, and one of the strongest regulations that requires landlords to reduce lead hazards in rental housing anywhere in the country. So these are some great examples of what can be accomplished. And these have, of course, been passed by bipartisan groups at the state level, and also a lot of work being done at the Baltimore City level. And similarly to Rhode Island, success has been measurable, and we've seen a dramatic decline in the children with lead levels rate over the years as legislation has been passed and implemented. And with strong enforcement, there's been a great deal accomplished. These are some of our numbers. And then in addition to the state of Maryland and the city of Baltimore, we have some indicators of success in some of the other communities where GHHI has been very active at the policy level, including Philadelphia, where we've seen fewer asthma-related hospitalizations and emergency department visits that have been thanks to the asthma interventions that are happening in housing through the partnerships in these cities, and similarly in the city of Cleveland, where we've seen measurable outcomes related to healthy housing policy. So a few resources to share, and then we'll leave a little time for questions at the end of the presentation here. We have the summer release, the strategic plan to end childhood lead poisoning, which is a 5-year plan to eliminate lead poisoning in our nation. And it's a really strong document that details work that can be done at the national level, but also includes recommendations for state and local policy to think about. So that includes some of the model legislation that we've discussed here that's directly related to lead and asthma and home injury prevention, as well as the increasing the level of resources for weatherization and energy efficiency in homes, but also making sure that we have support for greater cooperation among our agencies that are working with families that have healthy housing intervention needs. And so some things to think about there are making sure that our states are looking at ways that we can streamline the application process for various limited housing repair services, so families aren't having to fill out multiple applications, and we're not looking at various eligibility requirements for families to go through and things along those lines. And also a big issue that some communities can run into when they're trying to coordinate services is being able to share data across agencies. And that's something that we've seen where we've been able to create partnerships and memorandums of agreement that allow people to share data in a secure way to serve families. We've seen greater success in implementation of GHHI programs and partnering programs. So there, and Margarita mentioned Pay for Success, which is a financing opportunity that's being explored in several of our GHHI sites. And we've got additional information about Pay for Success, which we've done several webinars unto themselves just to cover Pay for Success and give a primer there. So if you're looking for information on that topic, please let me know. But in general, it's set up as a performance contracting financing opportunity for social services. It's the most succinct way I can describe it, and we've got guidance and some explanations in the download section of our website. So again, this is an overview of some other policy areas to think about, and I think we've just got a few minutes left here to wrap up. So please enter in any questions, and just wanted to share this map of where our GHHI sites are across the country if you're joining us from the Partnership for America's Children. And if you aren't sure where to connect with the GHHI and are looking for contacts, please share that request with me, and I've got my contact information at the end of this presentation. Be happy to try to connect you with any of the local partners if there's overlap, which, you know, since Partnership for America's Children is in all 50 states, if you're not already a part of your GHHI network locally, we'd love to help make sure that those connections get made. And I haven't seen any questions come up in the comments box, and I know that we've got some participants from GHHI sites as well as the Partnership for America's Children. So if anyone has any questions or comments at this point, you can enter them in, and if not, we will wait a few more seconds. And if there's nothing else, then we will adjourn, and I will say thank you for joining us today, and hope this was helpful. And again, here's our contact information. And Deborah, is there anything else that we can share before we adjourn?
Hi, I just wanted to say for your GHHI people, if you want to try and find out who the partnership members in your state, you can go to the number 4americaschildren.org. That's our website, and we have a list of all of our members there. So I wanted to make sure that your members had the same access to our list. Otherwise, I think this pretty much did what I was hoping it would do. And I do want to mention that the recording will be posted on the partnership website, so you can, and we'll send out the slides, so you can go back and refer to it as you work on this issue, or if you're not developing an initiative right now, but you decide to down the road, you can also go back to it and check it out then.
Great. Thank you so much, Deborah. And thank you, everyone, for joining us. And please follow up with us if we can help connect you to any resources that we covered today.
Great. And Catherine, thank you so much for setting this up.
All right.
Thank you.
Have a great day, everyone.
Thank you.
Thank you.